One of the, I think, significant secular trends that we're going to be dealing with as industry professionals over the next couple of decades, I think, is going to be increased significance in the emerging role of paraprofessionals or allied professionals in caregiving. So, by that I look at the primary care physician, the much ballyhooed primary care physician shortage. One of the ironies of the primary care physician shortage is that 2/3 of the people sitting in the waiting rooms of primary care, general medicine, internal medicine specialties today probably don't really need to see a doctor, right? Their needs could be met by less expensive and less hyper-qualified professionals. Exhibit A for that category of paraprofessional, in my mind, is midwives. Why a normal pregnancy qualifies as a healthcare or medical event at all is one of life's eternal mysteries to me. And I think that the whole midwife profession is one that lends itself to kind of automation and systemization. I checked yesterday, I had a meeting with the guys from Practice Fusion and asked if they had any midwife clients, and they said no. I know from my perch at Athena Health that they have very, very few, if any, midwives on their system amongst their 50,000 providers. So I'm very excited about what Brynne Potter, who I'll introduce now, is doing. I think these guys have a great niche here, and one that is speaking to kind of an emerging opportunity. Brynne is a midwife, yep. Correct? And co-founder of this enterprise. They come to us fresh from a first place finish at the Health 2.0 hackathon.
Thank you. I should maybe just let you present for me. You're a good spokesperson, thanks. Welcome and thank you for having me. I'm going to talk today about our startup EHR, Private Practice-Maternity. And just a little bit about us, we are a 4-person startup. We envisioned this idea about 2 years ago because I needed something as a practicing midwife that was more catered towards not just maternity care, but to midwifery care in particular. We recognized that there was an evolving spirit around large-scale EHR, and in the spirit of midwifery, which is really small-scale and relationship-based and more intimate, something that was a little bit more user-friendly, and potentially even identifying that most midwives, either in your knowledge of them or in your stereotypical knowledge of them, wouldn't necessarily be as tech-savvy. And we felt that if we could design a product that midwives could use and adopt quickly, then we would really have something within the specialty. So we actually have an install base and launched about 7 months ago, and have been able to amass 25% of the out-of-hospital birth center and home birth market within that time frame. And we really got shot out of the cannon and excited at the Health 2.0 Codeathon in Blacksburg, Virginia, about 6 weeks ago, and have found ourselves just sort of really thinking about where we fit in the space and where we're headed there. So sort of identifying as we think about that, where we are in the space as midwives and as maternity care EHR providers, and from the viewpoint of specialty is what is the problem? What are we trying to address with maternity care? And in some ways, the advantage of having this framework or contained system of maternity care as we talk about the general problems in healthcare is that some of the problems that exist in maternity care are really magnified. And part of that is because it's this contained system in which people enter in at a set point in time and exit in a set point in time. And those confounding factors that maybe would affect other types of healthcare problems that plague us are very contained and a little bit more framed in something. So those similar issues are having really big impacts. Obviously, an underuse of information technology and availability of a specialty product that focuses in specifically on maternity care. An incredible overuse of interventions because of our procedure-driven focus. And definitely being the #1 malpractice lawsuit issue is obstetrics, that general fear or reality of malpractice driving clinical decisions. And then just the disjointed system that we all experience is actually magnified again for maternity care, that idea of where you get care, when you enter care, who else has seen you, all these things can really have a really big impact. So can we use data to solve these problems? What are the problems we need to address? They're pretty significant, they're pretty powerful, and I think they're pretty measurable. And I'm not going to read out all of these, but just this highlight of where preterm birth is going. And if we just take preterm birth, and this is really what we addressed at the Codathon in terms of looking at how we can take data, not just a usable system, something that midwives like, yay, this is working well and I feel really good, but how can we really take data, bring it into the system, and make a difference in something as significant as the rise in preterm birth. It's the #1 NICU admission. And even more importantly is where this disparity is in terms of access to healthcare and what we're seeing across socioeconomic parameters, that there is a significantly greater rate of infant mortality as well as maternal mortality for women of color. So we really feel like taking that, our own story of a midwife-driven product and applying it outside of how can that be implemented into a care system that reflects a model of care and then be utilized from any provider perspective is what we would say is midwife-led care really is a triple aim for maternity care. And that's because fundamentally what is midwifery care is relationship-based. This aspect of having a focus on trust, relationship, communication, education as being the specialty that is midwifery-led care. And how do we then apply that into a system? What kind of came to us as we were saying, what would a midwife product look like? Also the intrinsic care coordination, that midwives don't practice in silos, that they are, because they're generally caring for a low-risk population, but they can lead care for a high-risk or any risk population because they are focusing on relationship, that they automatically, through our training, we are utilizing other providers. So it's very rare that a midwife would never consult. So we kind of already had an intrinsic awareness of what care coordination is just within our model. And the prevention piece is fairly simple because prenatal care is prevention care. So our highlights in prenatal care, and that's really where we've been focusing. What really is now, at this point, is our minimum viable product is really a prenatal focus on what we're doing. So how that manifested is in a mirrored EHR in which we've essentially integrated the patient health record piece by allowing the patient to see exactly what the provider sees. And this allows for an input of data as well as just a relationship, an accelerated relationship. And I think the best kind of an example of this would be how a patient profile is like your Facebook profile, in that you kind of have this accelerated knowledge of people that you've never met. You might meet your brother-in-law's new girlfriend at a party or something and realize that you actually know a lot about her because you've read her Facebook page. And that as we have this workforce shortage, as well as shrinking ability of time to have a clinical encounter, the average of 7 to 15 minutes, the need to accelerate and maximize that clinical experience really is fed by having patients engage directly into the health record. So just to real quickly, who's using private practice? In our 7 months, we have over 500 midwives, almost 200 practices across the country. Because we're web-based, we've been found by international midwives who are using our product as well and finding that it's really useful. But more importantly, that represents actually over 10,000 patients that midwives are sharing. They have the option to redact the sharing, but they are choosing to, and we are seeing that this is working. And I think, again, it's that high adoption is most of these providers are not even eligible for the incentives. So they're using it because it makes their quality of care increased, and we're getting a lot of positive feedback on that. I'm gonna show you this video that just gives you a little bit of clarification of how the client sharing works.
It's based on two things: ease of use and the ability to share your notes with your clients. Sharing provides a valuable closing of the listening loop. And it's also an incredible opportunity to document informed choice and shared decision-making. The written summary of what was said in your visit gives your client the opportunity to review what you heard and what was decided in the visit. From the To-Dos tab, clients can see a list of discussion topics that are planned throughout their care. They can also see those same to-dos checked off in their progress notes. To-dos are also a great way of providing educational resources and information that can help your client make informed choices about her care. By including the information within the progress note, you're not only providing them with information that is easily accessible and timely, but you're also documenting the shared decision-making process that midwives are known to provide. This can be done by linking to another website or attaching your own information as a file within the note. The to-dos can also serve as a reminder to return items or prepare for specific topic discussions at their next visit. We've also provided you with specific informed choice to-do list templates that you can use with all of your clients. You can also edit these or just make your own that perfectly fit your practice style and preferences. When you post a new progress note, your client will get an email message with a link to the note. Your clients can't edit their progress notes, but they can ask questions and comment on them using a message. They can also just reply to the email they received. Sharing the chart with your client lets them know they are at the center of their own care. Most women will feel empowered by using their secure login to view, download, or print their own labs, ultrasounds, or other critical information. At the end of care, you can use the same process used for sending records to other providers to give your client a complete professional history of her care. It's a wonderful close to a comprehensive relationship of care.
So I'm going to switch over here and just demo a couple little features, and I want to mention that I didn't say before the video about our use of the term client, which is not referring to your cell phone or how data people understand client. Midwives tend to use this word in place of patient, primarily because patient implies an inherent illness, at least in our minds, not necessarily in its literal meaning. So when we design this for midwives, it was sort of this opportunity. Midwives are often using all kinds of tools and systems that are designed for physicians. So there was a little bit of a heartfelt desire to acknowledge the semantic that is really just that. So you'll see that it's a little bit confusing that we don't have patients in our system, but that really is just a respect of, again, that it's not an illness, and also that this is who's working for whom, this little sense of breaking down those barriers of real relationship that's there. So this is in terms of, and in reference back to the video too, this is really kind of the opportunity for shared decision making really can't be understated, as well as what happened in that video in which something was declined. And I think in a lot of our data analytics as we're moving forward, I think one place where we're really at the forefront is really asking the question of how are we measuring non-intervention? And there's really no place where this is more critical than in maternity care, where as we identify a clinical quality measure as did this intervention have a desired impact, where are we asking the question of did the non-intervention have a desired impact? And that's really is something that I think midwives can bring to the conversation and bring to the table, and that I think we have the potential to do here. So what I want to show you really quick is the app that we built at the request of Anish Chopra at the Health 2.0. One of the things that we have in terms of clinical quality indicators, and again, this recognition and this benefit of the client as well as, or the patient as well as the midwife seeing this, this is the overview screen, and this demographic information could be entered by the patient at the beginning of care before she's seen the provider, or it could be entered by the midwife. And we're going to have her address be this convention center. Say she lives in this neighborhood. And what it will point out to us is that there's a little bit of an alert here. And the alert is that she is at a much higher risk of preterm birth if she lives in this neighborhood. And the reason is that this particular zip code has a preterm birth rate of 15%, and there are no access here for healthy food. So we are currently in a food desert, and there's a direct connection between access to healthy food and the risk of preterm birth. So what do I do as a provider? I'm going to show you, but I think I really want to make the point as well that as a patient, to be able to see that and have that information told back to me immediately as a patient, I probably have some idea of why there's an increased risk of preterm birth in my neighborhood, of what those stress factors are. And now I've really identified that it matters in the relationship with my provider, and that we're going to have a conversation about things that are outside of my control. But how do I get access? How can I find maybe access to healthy food, maybe something through WIC, or maybe access through a food co-op or a local food hub, and do that in the first trimester, because it's something to notice that most women don't get into care in the first trimester. And that actually pregnancy is usually a presumptive diagnosis made by the woman. I think the last app was showing that it's very few people who don't really know that they're pregnant. I mean, it happens, but very often you kind of put together the symptoms pretty easily and have a presumptive diagnosis that gets confirmed. So what can happen is once the provider is alerted that there's this preterm birth, they can choose to create a new prematurity prevention checklist. And that will automatically populate within the to-dos section that we just showed you with educational information. So this could take, and again, this is something that the provider can see or the patient can see, that gives a little bit more information and lots of resources about how to mitigate preterm birth. It could also take you to a link to give her a handout on nutrition, some patient education, and these are customizable, but we're going to sort of automatically put it into the system for you. The other thing that we can do is notice what other alerts she has, and she's an occasional smoker. So one thing that we might want to do is go in and send her a message using a PubMed link. And what can happen there is when we access PubMed, we could put in the risk and smoking, and then look through, these are just going to be the top 5 searches on PubMed, and we can look at this and sort of talk about the effect of smoking and environmental tobacco. And so I'm going to use this link, and it's just going to appear here. Whoops. Somehow I lost it. Preterm birth. I can actually just look at that article as well. I don't have to put it right in, but then I can send her a note and say, you know, here's some information that might help you make a decision to quit smoking. And then when I post that note, I'm going to send it to her. I could send it to other people in the practice, other care collaborators. And now it's here in the field. So we can look at all messages and see there. She could reply back to me, things are going well. I could actually provide her with other educational information, so I can attach a file. So those are the 2 primary external data tools that we've developed. And I really want to thank you for paying attention and for being here and for choosing us over Atul Gawande. I really am honored. Thank you so much.
Thank you very much.